Good afternoon, everyone. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At the moment, all participants are in a listen-only mode. For those that are connected by telephone and require operator assistance during the call, please press *0. For those online that require assistance, please use the chat box on your screen. I would like to now hand the meeting over to your host, Jan Bird, Senior Program Manager at CPSI. Please go ahead.
Good morning, everyone, and welcome to the Spotlight Series webinar, Policy Guidance for Reintegrating Essential Care Partners During COVID-19 and Beyond. My name is Jan Bird, and I'm with the Canadian Patient Safety Institute. I live and work here in Winnipeg, Manitoba, in Treaty 1 territory, home of the Dene, Cree, Ojibwe, and Oji-Cree people, and in the heartland of the Métis Nation. Thank you all so much for tuning into this webinar today. I'm just delighted to be here with you and the team on the screen to talk with you about this important work carried out in partnership between CPSI and CFHI. A few notes off the top. We are pleased to offer this webinar with simultaneous interpretation today. So if you wish to see the slides in French, please just let us know in the chat box and our producers will help you out. We do invite you to participate using either official language in our chat box on the bottom right of your screen. The team will be monitoring that chat to make sure that we address as many questions as you have as we possibly can get to and to get as many themes as time allows. We recognize that this is a unique time and that working from home during a pandemic means things may come up, like my COVID puppy barking outside the door, that may take your attention away. And that's okay, we understand that. Please know that this session is being recorded and you'll have access to it at a later time. Over the past few months, we hosted a series of Policylab sessions. In the lab, as we call it, we use creative methods to solve complex policy problems. It's a new way of doing policy that aims to involve everyone impacted and to design rules, policies, and services around people's actual experiences. The policy problem that we addressed was the no visitor policies that quickly took hold during the first wave of COVID-19 and has really been sustained for many months now. We know from our foundational work at CPSI and CFHI that caregivers play a critical role as essential partners in care, and we discussed the serious implications for every one of those policies defined as visitor restrictions. So today, we'll provide a brief overview of the Policylab methodology, as well as the outputs of our work, before we turn it over to our panelists, who are actually participants in the Policylab. We're thrilled to be joined by Donald Lepp, Jennifer Simon, as well as our own Julie Drury. Please take a moment, if you haven't already, to introduce yourself in the chat box with your name and where you're from. COVID-19 brought many policy problems in Canadian healthcare. Our Policylab used policy development methodology that was a mix of the UK's Policylab processes and good old design thinking to co-design better policy content and better policy products. And we had great support from the Canadian Pivot Group for the technical aspects of this work. When COVID-19 hit, what we heard was that the doors were closed, slammed even, on care partners in hospitals, long-term care homes, and other places where care is provided. This was a critical policy decision, probably done with the best of intentions, but it caused huge problems for so many groups of people. The unique aspect of our policy development process in the lab is that the co-design means we get the work done together with the users. In other words, all of those people who were impacted by the doors closing needed to get together. So that means we worked side by side with policymakers in government ministries of health, health system leaders in the delivery systems in jurisdictions across Canada, as well as essential caregivers themselves. So friends, partners, loved ones, neighbors, however that's defined by the patient. And we also spoke with patients with lived experience of COVID-19 themselves around the impact, what it was like with visitor restrictions. And even in advance of the policy labs, our pre-work included extensive research and environmental scanning, interviews with senior government policymakers and decision makers, again from jurisdictions across Canada, and health system leaders, providers, patients. One of the things that I remember asking everyone in those pre-interviews was, what keeps you up at night about this pandemic? What are your challenges and priorities? And, there were some different nuances depending on context, but I can tell you, even in the senior government decision maker policy table group, every single person was distressed about the complex problem and the decisions they had to make about locking out visitors. We took upon this work very carefully and recognized there is such a delicate balance that has to be weighed in order to get at how do we manage and mitigate the risks of the spreading COVID-19 infection when we don't really understand it and seem to be chasing that data. And how do we balance that with recognizing what we know to be huge benefits and important safety issues when essential care partners are present in person at the bedside? It was a challenge. So in our policy lab, we took care to bring forward individuals from those key groups that I keep mentioning. Those people who made the policies around visitor restrictions, those who had to implement those types of policies, and then those who were impacted by these policies, so patients and their essential care partners. With 7 policymakers in the lab, 12 policy implementers, and 9 patients and caregivers. What this balance does is allow people to listen deeply and to take the role of the other, which is so important in developing or redeveloping better policy. The virtual policy lab took place over the summer of 2020 over 5 sessions. And these were the key processes. Empathy, like I said a second ago, about taking the role of the other is so incredibly important. If you think about some rules or policies, you might think, geez, are they made in a back room with people who don't really understand the lived experiences? And they might be. So in innovative new policy design methodology, you got to get in the muck together. And that means maybe for me as a caregiver, I might need to sit with a policymaker and understand, what is this like for you? Why did you have to make that decision? And what bugs you about it, or what do you wish you could do differently? So that empathy is a really, really important way to set the stage and do better policy work together. I will mention the fact that this work was deeply emotional for almost everyone involved. It's really challenging, and it's hit us all. As we've gone through the lab, we've seen staff on this team, our partners in the lab, and others all had a personal story about how this is hitting home and how challenging it was and how we need to change these rules. So we took care from the outset to have emotional supports in place. We had trauma-informed counselors available on the call in every policy lab, in between calls, and for after, to debrief and offer that support to everyone involved, be they staff or volunteers or participants in the lab. And that was really, really a good and important piece to put in place. The other pieces in the process, decide. So we explore the landscape together. Then let's look at what are the really dicey pieces of that problem that we need to get at and solve together. Ideate. So let's come up with some policy options. This is the new way of doing it, right? Not in a back room without testing things out. Let's come up with ideas. Let's prototype them. Let's make an ideal map. Let's take it around to our partners in the jurisdictions, be it a small hospital in Winnipeg or a big, huge one in Ottawa, and say to our partners, hey, can you walk this around with your executive team? I get it that you're busy, but we need your opinion and we'll help you. We did lots of that testing and iterating. We're excited to share this methodology with you in the future. So for more detail on the process of the Policy Lab itself, you can visit the CFHI website, and we should have that out ready for you this winter. I'm now going to turn it over to Jenny Buckley, my colleague at CFHI, who will provide a brief overview of the policy guidance that resulted from our Policy Lab process. Jenny?
Thanks, Jan. My name is Jenny Buckley, and I'm a Senior Improvement Lead at the Canadian Foundation for Healthcare Improvement. I'm joining you from the traditional and unceded territory of the Algonquin and Anishinaabe people. As Jan mentioned, the Policy Lab was designed to provide guidance to stakeholders about how to reintegrate essential care partners during the COVID pandemic. I'm also hoping this guidance will be useful in the future if there are similar outbreaks that we have to deal with as a health system. So this policy guidance will be shared in various formats, including reports, visuals, and learning supports. But just to get us started, from all the discussions that we had with our Policy Lab participants, we were able to identify 3 overarching guiding principles to inform the implementation of this guidance at healthcare facilities and congregate care settings. So firstly, there's a need to differentiate between visitors and family caregivers as essential care partners. One of the challenges at the beginning of this pandemic was that there was no clear distinction between those that were doing social visits and those that were providing essential care. And so it became challenging because the decision was made to shut out all visitors without recognizing that essential care partners are not, in fact, visitors. Second, there's a need to recognize the value of caregivers as essential care partners. And not just to recognize it, but also to make sure that it's well established within the policies and procedures in an organization, and that they're really recognized as a member of the care team and someone that cannot be you can't eliminate these care partners and expect patient care and patient safety to stay at the same levels as it would with those essential care partners at the bedside. Finally, ensure that patients, families, caregivers are part of the development of policies related to visitors and essential care partners. What we heard from a number of our Policylab participants was that these decisions were made in sort of isolation without taking the opportunity to actually consult with patients or caregivers, even though they had been fairly well involved in hospital or congregate care setting, decision-making processes beforehand. And again, recognizing at the beginning of the pandemic, no one really knew what was going on, but there's a need to make sure that moving forward, that patient and caregiver and family voice is fully reintegrated into the process. So while there's a recognition that facilities will take different approaches to reintegration, depending, of course, on local context, number of outbreaks, resources, staffing, etc., these principles are really meant to be top of mind in any decision-making process. So based on feedback from our Policylab participants and also needs and pains of stakeholders that were identified through an interview process that we did in advance of the actual 5 sessions, we created an evidence-informed map that supports the reintegration of essential care partners in health facilities and congregate care settings during COVID-19. I understand it's a little bit busy on the slide, but it can be characterized into 3 main sections. So the first one happens before the care partner actually enters the facility or congregate care setting, and it's really the identification of essential care partners. The second actually talks about entry into the facility, so what that looks like, how the screening takes place, whether there's PPE provided, etc. And finally, the third phase is caregiving, which again wouldn't look too terribly different from before the pandemic, with the exception, of course, of there being a greater emphasis on, protocols related to infection control and prevention. So based on feedback from the lab participants, we decided to focus the development of our policy guidance on sections 1 and 2 of the map. Participants noted that these were the most critical to ensuring that essential care partners could get into facilities and provide essential care. So moving on, this table here provides sort of a high-level overview of the policy-level guidance for each of the key points in the first 2 phases of the reintegration map. In the pre-entry phase, focus should be on establishing the importance of essential care partners, as well as preparing care partners and staff to work together to provide essential care to patients. This guidance helps to create trust and mutual expectations before the essential care partner enters the facility. In the second phase, the guidance outlines the processes that will help make entry into a healthcare facility or congregate care setting as seamless as possible for essential care partners as well as for facility staff. Outlining a clear and evidence-based screening process, properly identifying care partners and providing any necessary PPE, as well as updating care partners on any new information are all covered in this phase. As with the guiding principles, this is not meant to provide step-by-step instructions to healthcare facilities or congregate care settings. Policylab participants recognize that each facility will have a specific context and specific resources. For example, some hospitals may have the ability to have a designated person to coordinate essential care partners. Others may have to rely on a number of different people to fill that particular role. So they didn't want to be prescriptive, but just sort of outlining some principles for consideration. So as I said, meant to be guidance and considerations that should be integrated into any process that healthcare facilities or congregate care settings develop. The real strength of this guidance is that it was co-designed with input from patients and caregivers, policy implementers such as frontline staff and healthcare administrators, as well as healthcare policymakers. So it really combines the needs and and hopes of those 3 different groups into guidance that we hope will really be effective and helpful for people that are struggling with us at the front line as we continue moving into the second wave of the pandemic. So I will now turn it to Jan, who will get us started with our panel discussion.
Thanks, Jenny. So it's time for the panel discussion. A reminder that these panelists were participants from the Policylab sessions, and it's our honor to introduce them again today. Bringing the policy implementer perspective, Jennifer Simon, Senior Consultant Engagement and Patient Experience from Alberta Health Services. Bringing the patient caregiver partner perspective, as well as being a board member on the Winnipeg Regional Health Authority Board of Directors, Donald Leff. And bringing a patient and family engagement perspective, Julie Drury, Strategic Lead Patient Partnerships at CFHI. So Donald, I'll start with you. Were there any aha moments that you had coming out of the Policylab?
I would say several. I guess one of the things that always kind of amazes me when we get together with patient partners is we're a very diverse group, very different perspectives and backgrounds, but what seems to come through again and again is the consistent message of how we want to be treated and, being respected and having, we have a lot of commonality when it comes to how we want our healthcare delivered and how we want to support patients and this kind of thing in the healthcare environment. That always seems to be a consistent message. I guess one of the things that also struck me was I've been involved in policy development and involved in initiatives like Better Together from CFHI, and there have been a lot of really good family presence policies developed in this country, and at the first sign of pressure on the system, it was abandoned. And maybe that's a personal thing that I kind of feel slighted a little bit by that, is that I've heard so many comments from people over the years when I've spoken in public, the positive reception that I get over and over again about how family caregivers are important and the value that they add, how they improve patient safety, but then we put pressure on the system and then all of a sudden that's all gone. And I think I'm still smarting from that, to be quite honest with you.
Thanks, Donald. It's been absolutely devastating. Yeah. Jennifer, aha moments for you from the Policylab.
So I think it was good to hear that it wasn't just an Alberta problem, that all of us were struggling with it, that there was a ton of emotional distress that both our patients and our staff were going through. I think the aha moments were likely different for everybody. There were so many pieces that everybody brought that was different. In some ways there were so many people that were ahead of us, and in some ways we were ahead of others. And the sharing was so great to hear the robust ideas from everybody and to be able to, walk across the country and kind of steal great ideas and share great ideas for everybody. And so I loved hearing some things around the essential caregiver education. Some people talked about online screening tools to make it more efficient and effective, so that wasn't so much delays. Looking at how we could do front-end education so that we were being really transparent. These ideas really resonated with us and allowed us then, as being part of it, to action these things, as the conversations were going here in Alberta, versus waiting for the documents to come out. And I know there'll be more robust things that we get as the documents come out as well, but the learning of being involved and part of the conversation brought us forward right in those moments.
That's wonderful to hear. Thank you. Julie, aha moments for you.
Thanks, Jan. Can you hear me? Okay. So, just echoing a bit of what Donald and Jennifer shared, that there was a real willingness to share amongst the group, and I think that was the creation of safe space in this Policylab, and that was really important, right, to be able to openly share that we were sharing in confidence, and that, everyone who's dealing with things from at a political level or an operational level or dealing with their boards of directors or their jurisdictional situation could be open about what was happening in time of COVID, and then families could be very open as well about the impact that it was having on them, the challenges that they were facing, and the incredible distress that was occurring across the system. So we really, there was a real sense of collaboration and co-design and sharing, that safe space creation, which was extremely valuable for this process. And then I'd say the other thing that was really an aha moment for me was the amount of education and sharing that occurred. I think there was a few aha moments for participants, right? Not realizing that this truly is evidence-based. This is founded in research, that when you remove family caregiver presence, you risk not just patient experience and satisfaction, but you're actually risking safety. You're introducing harm into the healthcare system, and you are negatively affecting outcomes. And we've seen that across a multitude of sectors, from medication error to prevention of falls to concerns around mental health to the challenges for persons living with dementia, to transitions in care, where family caregivers are significantly part of that role of transitioning from hospital to home, for example. And so I think there was a lot of aha moments in that. And then for the family caregivers, hearing the challenges from the sector about, we don't actually have access to infection protection and control equipment, or we're worried about, risk of transmission and we don't have enough evidence or knowledge there, or, we need to create some different sort of patient work flows and staffing workflows to be able to handle the new measures that are in place, and then the introduction of family caregivers. And so lots of, aha moments amongst the group as well. And then, once everyone kind of got through that sharing, it was getting down to that collaborative work.
So I'm just going to change tack a little bit and just ask the panelists, what are your hopes in terms of how the policy guidance from this report can be applied? Jennifer, I'll start with you.
Those broad restrictions of the spring, hearing from our staff the angst of separating families, fathers missing their kids' birth because they were waiting in the parking lot for permission to get an exemption, people missing their parents' deaths and end-of-life care because we were restricting numbers and they had a bigger family. Just all of those parts and poignant pieces. Hearing from patients in our palliative care who were having pain crisis and didn't want to go into hospital because they couldn't have their family with them, and so stayed at home in pain. And so I really hope that these documents, that they give us a bit of leverage to remind us that we can't go back to that, that there was clear and measurable unequivocal harm done not only to patients and families, definitely to patients and families, but to our staff as well, as we put them in a distressing part where we told them that patient-family-centered care is premier to be considered, and then made broad strokes that really morally went against what they'd been actioning for their whole careers. And so I hope that this gives us a reminder of what better to do and lessons that we've learned from those spring days, and the reminder that we need to do better and we can't go back to that. And as numbers climb, it's more and more poignant that we remember the harm that was done and that those things actually, we have to manage the risk. Never before has visiting somebody been something that could be deadly. But not visiting is just as deadly.
Donald, what are your hopes for the policy guidance? Donald, I think you're on mute. Could someone open Donald's line?
Can you hear me now?
Yeah.
Okay. Okay, I don't know what happened there, but so just to get back to what my hope is that we get to the point where we have a mechanism of taking a lot of this information and putting it in the hands of patients so that they can advocate for themselves. One of the harsh lessons that I've learned in this is that when we've encountered a pandemic of huge proportions, and this is a personal opinion, I mean, we've gotten a little bit into tribalism, is that we've pitted, different organizations against each other. There's blame. And the thing is, who is really representing the patients? And the thing is that in my personal experiences, we've had to advocate for ourselves. And with this information, can we do a better job of it? And one of the things is that as patients and caregivers, we don't have the luxury of living in the theoretical. We live this, so we have to apply it. And so next Monday, my son is having surgery here in Winnipeg, and I'm right now advocating to have both my wife in there present with him for various reasons. There's reasons behind that. So I'm using some of this documentation. I'm using some of the good policy development that has been done related to Better Together. We have a family presence policy in our region, and I'm going to be using that. You can talk to me in about a week and see how successful I am.
Thanks for that, Donald. And Julie, from your perspective, what are your hopes for this policy guidance?
Yeah, so briefly, I have expectation that persons who are developing the guidance, the recommendations, the policies at a very senior level provincially are going to have a better understanding of the risks and the harm, and will have a much more balanced approach. So we need to right the scales on this and understand that the risk-based approach that's been currently in place, which is around visitor restrictions and concerns about transmission, need to be balanced with the harm that has occurred because of the restrictive policy. So that's the first. The other is that the scope of this is not just hospital-based. And although our policy lab was very much participants from sort of a hospital and acute care background and context, we have quickly realized as two organizations, CPSI and CFHI, as well as across the healthcare sector, that family caregiver presence isn't multi-jurisdictional. So this is long-term care, this is hospital care, this is places where there is congregate care settings of residents, children and youth and adults with developmental disabilities, for example, where they need access to their most essential care partner. So crossing jurisdictions and being very clear of that differentiation between a visitor and a family caregiver. And as Donald said, we in this country have had very strong family presence policies. In fact, between 2015 and 2020, we went from 32% open family presence to 73%. That went to zero in mid-March of 2020, zero. And so what we're looking for now is not open family presence. We are looking for essential care partners who are designated by the patient to partner in the care, to be present, to ensure the safety, the experience, and the positive outcome of those patients and residents and clients.
Thanks, Julie. I'm going to stick with you for the next question, if that's okay. What do you think are the main challenges to having this policy guidance adopted?
Yeah, that's a great question. Jan's probably going to want to weigh in on this one as well. Really the challenges are the political kryptonite of COVID. Let me just sort of call it the elephant in the room. I want to be really frank and honest here. Nobody wants an outbreak in their facility. And so in an effort to, curb potentiality of transmission, of which we have no documented evidence, there's some anecdotal stories of family caregiver transmission, but it's not been yet documented, and multiple reports demonstrate that with good use of PPE, that we don't have family caregiver transmission. But there's concern about that, about more people you introduce into the space, the more risk of transmission. So that's it. The other barrier to this is a lack of appreciation or understanding by administrators or healthcare providers or staff, and not all, definitely not pitting everyone with the same brush, but there is a lack of appreciation and understanding of that essential care partner role. I've been working with a family, for example, in a province who's reached out to me to help them navigate this, and their direct provider said to them, "What do you think will be different if you're actually here?" And that's a real naive statement by that healthcare provider to misunderstand and misappreciate what that essential care partner role brings. And so we have a lot of education to do in the system, and I think those are right now our two biggest barriers.
Thanks, Julie. Jennifer, from your perspective, what do you think are the biggest challenges to implementation?
Yeah, I agree with Julie's staff's fear of an outbreak. These myths or feelings that visitors are contributing to outbreaks, that they're bringing in Despite solid evidence, it is definitely a poignant fear that we hear on a regular basis. Both a fear of workplace health for themselves, a fear for their other patients, organizationally a fear for the reputation seems to be in the air. I think as community numbers climb too, we can't compare this anymore to like hospital-acquired infections that we know actually go down when family presence is around, and it becomes a bit trickier to have those conversations that there is still essential things that they bring to the team, that these aren't just nice to have, these really are need to have, and they need to also be able to do the things that they need to do to keep you safe. Being present in those times where it's important for discussions, if that's where they need, and to help with decision making. And it may mean a change in the way we do our work too. I've worked with doctors lots of times, and the patient might come by and say, when does the doctor around? I want my mom or my sister here for that. And we're like, oh, I don't know. Like sometimes it's 8, sometimes it's 10. But I think as we move into this world where we're looking to decrease the numbers or the frequency or duration, we as an organization need to get really clear about what our schedules are so that they really can partner at those essential times and feel free to be safe at home in those times where they don't need to be there, rather than waiting all day for maybe the doctor to show up. And so, I think that there's lots of examples like that. And maybe it's not just doctors, it's when are we going to do a wound care dressing change, when are we going to talk about med changes or do some education with diabetic care. There are essential things that these people are partnering with every day. And we need to make sure that we are really able to communicate and schedule those things so that we can invite those partners in.
Thanks for that, Jennifer. And Donald, from your perspective, what do you see as some of the challenges we're facing in having this policy guidance adopted?
I think one of the challenges we face is, are we talking to the right audience? We've talked already about some of the excellent how caregiver policy has evolved and improved. The thing is that what shocked me was the pushback that we got from certain parts of healthcare that where patient and family-centered care have never really penetrated. So we have a whole group of people out there who have never really heard some of the topics that we're talking about today. When I look at many of the comments that I see scrolling by, many positive comments, I view this as a very friendly venue to have this conversation, but the thing is, there are venues where it won't be that friendly of a conversation, and we need to have that uncomfortable conversation with people who do actively resist. One of the experiences that I've found out is that when we were implementing our family presence policy, there was a great deal of resistance and a lot of skepticism from many parts of the healthcare system. And we really need to get in front of those people and really have that discussion. And leveraging patient stories and our own experiences of what has happened during COVID, I think paints a very stark picture of what has happened.
Thank you, Donald. And I do hope Russell's surgery goes really well next week. I'll be thinking of you guys. So, we have all heard the stories. I feel the devastation and I feel the urgency. And that's why we're all compelled to get up and do this. And we've all been impacted. Yet I'm starting to also hear some hope, and I feel this sense of collective effort brewing. And I think this is a moment for us. We know that we can support the jurisdictions. CFHI and CPSI have come together, if you hadn't heard, in a new, larger and better amalgamated organization. And we are so focused on making better policy around reintegrating family essential care partners at the bedside. So let's anticipate a bit. We can get out there and help and support and do the work in this moment while acknowledging the fears. Okay, government, policymakers, system leaders, you're afraid. We understand that. And maybe until you've lived through this, it's hard for you to take the role of the other. But we're still going to try and support better policy and influence. So final question for the gang. Let's anticipate a bit. What's it going to take for this policy guidance to be implemented and to stick? Jennifer.
Yeah, so I'm ever aware of how much government and the chief medical officer play in setting the stage, especially as case numbers in our communities rise across the nation, really across all of North America. And so I think, this policy really gives them the evidence to have a better conversation, to hear the voice and to hear the experience across the nation of what we can do and what our possibilities are. I think now more than ever we need to have education about the benefits of family presence. People need to understand that this is not a nice to have, that this is a need to have, and not something that we can leverage for safety, that this is safety. I think, as communities we have a role to play in keeping our numbers down. It's a lot easier to welcome people in when our numbers are low with COVID, and so there is that piece too, and recognizing that, as we ask you to come in and invite you into hospitals to be a part of partnering with us and us partnering with you, that there are things that you can do to keep us safe as well, and that all of us have that role. We need to have some clear research and some clear understanding around the safety that families do bring to us, and that it isn't as much of a risk, or we're not seeing the evidence of that risk as much as the fear is leading to it. And so we need to make sure that as we move into these next stages, we're not being reactive, but we are working from the evidence that is there.
Thank you. So we're going to have to keep sharing the evidence that we have and keep socializing around the important safety role of essential care partners and the real difference between visitors and essential partners in care. Thank you. Julie, over to you. What's it going to take for this policy guidance to be implemented and for it to stick?
I thought you were going to say one thing for a moment there, Jan, and I mean, you know me better than that by now. So, just echoing much of what Jennifer has said, but, caution, I don't want to put that on repeat. It's very much about persistence and perseverance in sharing the information and the evidence. And it takes time to close that gap in knowledge transfer and adjusting policy as a result. And so, as Donald said, getting to the right table, getting to the people who have not heard this message, who do not understand or appreciate it for what it is and the impact that the current directives are having. And the need to sort of rebalance, as I was saying earlier, that risk-based or harm-based approach. So getting to the right people, getting to the right tables, and being persistent about that. I think the other piece, and I'll talk about that near the end of the webinar, is supporting the how. And so in many of the organizations that I've spoken with, as we've been sort of, ideating the work of the Policylab and sharing our map for the reintegration of family caregivers and sharing our the language around the policy guidance, a lot of the feedback to me has been, well, how do we do this? Let's get into, like, what does this look like? How do we support our staff? How do we support our patients and our essential care partners? And I think that'll be another big part of this. Well, that will also help to hopefully move the needle on how policy decision makers being more supportive. They've got an action around it.
Thanks, Julie. And Donald, over to you.
Jennifer and Julie, you can hear me now? Okay. One of the things that's important is that basically the whole concept of keeping the pressure on, that we need to keep this conversation going and we cannot let it drop. We've had an interesting journey in our province as it related to COVID. When we started the Policylab, I remember even saying on one of the Policylab discussions, well, I was even gloating how well our province had done. This was back in early July. We had almost, we almost had no cases, and the province had done a fabulous job. Now, in the fall, since mid-October, our cases have exploded, and we're now in a situation where the city of Winnipeg and some of the surrounding regions are under a code red. And so the thing is, some of the early discussions that we had in May and June about family presence was, okay, we're in the middle of this, we can't talk about this right now, we'll get to it later. And then when the pressure was off, it's like, oh, okay, we have time, we can push it down the road a little bit more, we're just recovering, and then now the situation has come back in force. And so we can't let this drop. This issue is going to come up again and again. And so that's where we really can't afford to let this issue drop for other priorities. This is really important, and we really need to emphasize the importance of this. As already has been mentioned, this is evidence-based. This is about patient safety. This is about improving the entire patient experience. There is lots of data to support this, and we can't afford to let it drop.
Thanks, everyone, for those great insights and that great conversation. We now have about 10 or 15 minutes for questions from the audience of our panelists. So if you can type your questions into the chat box, and Jan and I will keep an eye on them and bring them to the panelists. So I'll give people a few minutes to type away. See lots of great comments in the chat box. I'm not sure I see any questions yet.
Just noticing one comment that's always really important. Who is missing in the conversation? And that's something that we need to do every time we pull together a group to talk about an important policy problem. Whose voice isn't at the table? Who's missing and why? And so can we give up a seat at the table? Can we make a bigger table? And if there's just they are voiceless or silenced, it's really, really important that we get out there and find ways to connect. So I know at both of our organizations, we're connected into all the provinces and territories and cities and formal and informal networks, and we would rely on you as well to try and get the word out there that we are doing this good work. We want to share the report once it's ready, and that we want to stay in touch and connect and hear how things are going for you and how we can be of a support as you move through this.
So one question that in the chat box, basically the question is, would it be helpful to have a federal policy directive that all health social meetings will have patients and families present and a minimum number if possible? And the question being whether or not having a federal directive along those lines would help motivate the provinces to do something in terms of reintegrating caregivers. Julie, you want to take a shot at that?
Yeah, I'm sure, Jenny. So, it's a great question, and I think it has to do with understanding what the Canada Health Act sort of denotes in terms of who's got responsibility and agency over how our healthcare system functions. So you could have a federal sort of directive or reflection on this, but this is provincial jurisdiction. This is up to the provinces to decide what's going to be happening in their own jurisdiction, and quite frankly, in some provinces, that responsibility is actually delegated to the officials that are leading the health facility themselves. So in instances of hospitals, it really might be up to the hospital CEO and their board of directors to decide on what is going to be the functional policy for that organization. So it differs across provinces to territories, and it differs across jurisdictions. So it's really not a federal responsibility. I think what we potentially could consider at a national level, pan-Canadian level, maybe the feds would be interested in this, is thinking about a caregiver bill of rights and recognizing the multi-billion-dollar unpaid healthcare workforce in the country, which are caregivers, and the amount of infrastructure that they provide to the healthcare system across every province and territory of this country. And I think that's something that needs to be thought about, perhaps in this time of pandemic, but definitely on a go-forward basis.
Thanks. Here's another one. Wondering if there is any sense of health organization legal departments warning of liability risk to patients and workers as a driver to strict barriers to family caregivers. Jennifer, do you want to try that one?
Yeah, I don't feel like that's a resounding piece. I think each of us as staff members going into healthcare, we have this huge sense of do no harm. And so I think the pressure is more internally in us trying to find a way to do no harm in not letting people in and to do no harm in spreading COVID. I also think that, as the first policies came out, there was there wasn't enough information for us to know what harm looked like and what the risk was. And so the broad base came in, and there was this tension in that we felt like we couldn't break policy, but we didn't feel like it was quite what it should be, and so there was this kind of this pull of a tug of war between, you know, what we morally and compassionately felt was proper and what we were being directed to do, when we didn't have enough knowledge to kind of understand where we could let compassion mold the decisions we were making. And so I don't get a huge sense where I'm at that legal's pushing a harm-based approach, but I do get a sense from our staff that there's that real struggle between compassion and harm.
Thanks for that, Jennifer. And Donald, I'll give you the next question if that's okay with you.
Sure.
Moving forward, can you reflect on what's needed across the health system that will enable patient, family, and caregiver partnership even in times of crisis? So what are the lessons that we can take from Wave 1 and Wave 2 to apply moving forward?
I think some of the lessons we can take going forward is, I guess, kind of getting back to, I think we've talked about some of these lessons already, but you know, just to try to expand upon them a little bit more is you know, carrying this message to places where we haven't taken them before. The one thing, there was also a question about, you know, a federal directive or something on this line, is that most of us who in the patients and caregiver world, we're in the grassroots. So I guess for a counterpoint to that is, can we build this from the bottom up instead of the top down? Is that a possibility? I don't know the answer to that question. Can we change things right at the frontline level? Because I think one of the biggest issues in healthcare is always the communication piece between patient and provider, and even within the groups, nurses to doctors, administrators to frontline staff. All of these communication pieces, we need to build that culture, and I think that's what was missing. Why we feel so slighted about a lot of these policies, where it feels like we're rewinding the clock 30 years to the dark ages of patient and family-centered care. That's the problem, is that we've kind of reverted, and it's like, so we have good policies in place, we have a lot of people who are saying the right things, but when it comes to actual delivery, we're failing. And so the thing is, that's where we need to kind of change the culture at the grassroots level, and that is my hope moving forward, is that we can start having some of these conversations, and this starts with educating patients, educating caregivers, and then dealing with some of the frontline staff. And like, we're putting a lot of pressure on our frontline staff, a huge amount of pressure. They're on information overload. They're getting a different policy directive every second week. Then we're going to come to the table and add more to it. So we have to recognize some of the pressure that some of our other enabling groups are under as well, but still have that conversation. We can approach this respectfully and reasonably, but the thing is, really moving forward with this as a bit of a grassroots conversation.
That's a great point, Donald. Thank you. And we know that it takes a real engaged and sometimes enraged group of people to really make things happen. And so grassroots, absolutely. And that's that moment I talk about where you can feel in every province and territory we're going through this. And so we need to start working together at that level. And we will also work at other levels. Policy influence, policy change takes a number of different inputs and levers to pull and push. And so that's what we've gotten pretty good at our organizations, and we have the tables. So we will work with people in senior decision-making capacities, and we'll work with health system leaders, and we'll rely on you to partner with us to have those conversations together, because the experience of patient and resident, client, caregiver, family always makes more of an impact. And so it's about that ability to listen deeply and have people take the role of the other. So I think we're going to need to work at many, many levels here. Just another question. Pamela says, really struggling to get congregate care agencies for disabled people in Ontario to recognize the essential nature of family caregivers. Would love resources specific to this issue. And you know what? We've been working in Manitoba on the same thing. So I know Leslie Udell from Abilities Manitoba is on the call today. And so we can make sure that you're connected together afterwards. And I invite any of the panelists to discuss this question or comment.
Yeah, I'll just add if I can, Jan. Can you hear me okay? Yeah, so you know, one of the things that Pam brings up as I read her question is, you know, we talk about family caregiver presence in terms of preventing harm and ensuring that safety of that patient, that resident, the client. It's not just about their physical safety and physical harm and outcomes. It's also got to do very much with mental health, emotional wellness, cognitive stimulation, and in these congregate settings with young persons and persons with developmental disabilities especially, separating them from their essential care partner is highly damaging. Again, this is evidence-based, we know this, and so the physical risk harm might be different or not as obvious, but that decline, and it can't be filled by a staff person. And they're great staff people, but having a young person or a young adult or a child for that matter who hasn't seen their parent in 9 months or their sibling is extremely harmful. And again, it's the taking of perspective and putting each other in one another's shoes. And so how do you adjust that? And Pam's call for meaningful resources in the space is well taken, and we need to think about that. And so one of the things that we're hoping to do, to shout out to all of you, is helping us crowdsource really good resources, materials, learning tools that might be out there that you are aware of, that we can help to share, spread, and scale, not just within your own individual jurisdiction and province, but across the country. And I want to make another point too about going back to Donald's reflection on, you know, getting to the right tables. Patient engagement and patient partnership has been around for a long time. Donald and I have been working at this for a long time. We've known each other for a few years, and it was very challenging, disheartening to see the significant shift in wave one of this pandemic of essentially those patient engagement and partnership opportunities shutting down in the policy space, in the program space, within healthcare organizations themselves and their patient and family advisory tables, and within research. And it was really across the board. And it was only jurisdictions that had a very strong, robust infrastructure and a long track record and history of working with patient, family, and caregivers in a collaborative way, in a co-designed way, where it essentially survived. But in many jurisdictions it did not. And so what we're seeing now are the effects of that. We're seeing policies that aren't working, that aren't effective, that are potentially creating harm, and that's honestly because we haven't had a collaborative approach to this, and we haven't had that lived experience lens, and we have people who are now challenged of living with the policies and directives that we're putting in place that weren't part of the development of it. And so patient engagement and patient partnership, you know, as we are entering wave 2 of the pandemic, really needs to be shored up. We need to bring patients with lived experience and family caregivers back to the table, and we need to be collaborating and co-designing. And we learned that through our Policylab process. We had a very robust process and a very strong result because all of the persons who are affected by this pandemic and by what we were studying were at the table together.
Thanks for that, Julie. We only have time for one more question, unfortunately. And Donald, I'm going to turn this over to you to start the discussion. Getting a question from Carol Ann, wondering, you know, with the large number of caregivers in each province, how do we organize to make change instead of trying to change it individually or on a patient and family advisory council? Just a recognition that there's such strength in numbers. So any suggestions?
That's something I've struggled with. I think, and again, this is maybe a little bit my jaded point of view, but I think in the past we've had some good partnerships with, I can think of off the top of my head, the Family Physicians of Canada, Canadian Medical Association. Some of the nursing organizations have been very supportive of patients and caregivers. But the thing is, that was my frustration when this all came down was that support wasn't really there, and we were kind of left on our own. And that's probably a different experience to different people. That's my personal take. But the one thing is, do we need an organization that is of patients and caregivers, for patients and caregivers, and that do not have to depend on some of these other groups to get credibility? We need to be credible as an organization on our own, not that we happen to be associated with another group that has credibility. CFHI and CPSI do wonderful things and are good organizations, but we need to have caregivers and partners. I think we need to be organized on our own and be able to stand on our own 2 feet at an organizational level.
Jennifer, any thoughts on that? Jennifer?
I'm not sure. Sorry. So many reflections right now. Can I come back to it, Jen?
Of course. Actually, we're at time for the panel, unfortunately. Thank you all for your great insights and great conversation. And based on the number of comments in the chat and the great discussion we've been having with panelists, I think this is a conversation that's going to be ongoing for quite a while, and certainly very encouraging to see the level of engagement on this webinar, and hopefully we continue to expand the number of people that are sort of fighting for this and working really hard to get caregivers back where they should be. So I'm going to turn it now to Julie. Julie, if you want to spend some time just talking a little bit about some upcoming programming that people might be interested in learning about.
Yeah, thanks, Jenny. And we have a slide on this. I'll just wait for it to come up for the participants. I love the title of this, New Programming Coming Soon. And so, Jenny and Dan have been great at sharing our Policylab process, the guidance coming out of it, and wonderful to have Jennifer and Donald, who are participants in that work, to be able to sort of, share their experiences with that, and all of us our thoughts about how this might be implemented. One of the things that we'll be doing at CFHI, CPSI, so really co-branding this programming, is supporting the how-to. So we understand that, the call to action that we're putting out, which is ensuring that there's a difference between visitors and essential care partners, and asking for essential care partners to be welcomed back to all healthcare facilities or congregate care facilities or residential or long-term care facilities, needs support. And that it's not just sort of an easy to do, an easy win, that we need to understand how we can educate and support and create awareness amongst staff, that we need to be able to educate and support and create awareness amongst caregivers and essential care partners, that we need to think about the tools and resources that might be needed to do this in a supportive and constructive way. And fortunately, across this country, we have a lot of smart people and a lot of great organizations who've already started to work and already have tools and resources developed, such as caregiver ID programs, tracking and tracing. I was recently speaking to a fairly large hospital that actually has an app where they can do contact tracing of any essential care partners that are coming into their facility, and they know at any given time how many care partners are actually present in the building. We have organizations who are working on wayfinding because we want to make sure that we're keeping our physical spaces in these facilities secure and ensuring essential care partners are only in those spaces where they need to be. And so this is a long list of the types of resources and tools and learnings that we are going to be making available through new programming. We are looking at coaching and mentoring and building upon a self-assessment that organizations can do to identify where do they need the most help and where might they need the most support. And then we're going to target our tools and resources towards those needs. And then we're going to track. We're going to see, what change is occurring over time, both in this time of pandemic, but even beyond pandemic. This is a long history of program work, that CFHI has done and now in partnership with CPSI. And so it's really not leaving you hanging with this call to action and this policy guidance, but it's ensuring that you're supported to actually operationalize this. And so you'll see an email on that page. Jessie Checkley is a Senior Improvement Lead at CFHI. She's been exceptional in leading the structuring of this program work. She's going to be the person that's really sourcing out all of these resources. But again, I'm putting a call out to all of you to share with Jessie if there are tools, resources, learnings that you know would be helpful in this space around reintegrating essential care partners into all healthcare, congregate care, long-term care, residential care facilities, then please share them with us. And we are going to do a scan of those tools and resources and make sure that the best available are posted and part of this, this program. And so, yeah, we're happy to take questions and comments. Again, just feel free to reach out to Jessie, or I can also share my email in the chat box. Thanks, Jenny.
Thanks, Julie. And I just want to say a big, huge thank you to everyone that participated today. We really hope that this webinar and the policy guidance that will be available, hopefully very shortly, will really be helpful for you in terms of figuring out how to reintegrate essential care partners during this pandemic. Also want to say a huge thank you to our wonderful panelists today. Thank you, Donald and Jennifer and Julie. It was a great conversation. And so thanks for taking the time to prepare to do this, and also for you know, having such an interesting conversation. So the last thing, because we're actually 1 minute over time, we've got a couple of poll questions for participants just to help us make the webinar experience a little bit better for the next time and in the future. So if you could take a few moments to fill those in, I will say again, thank you for participating and have a wonderful rest of the day.
This concludes today's webinar. Thank you, everyone. You may now disconnect.